Hi everyone, it's Derek here from AduMed. Welcome to today's video on heart failure. This can be quite a meaty topic, and I'll aim to condense this down into the most important aspects. We will look at the diagnosis, investigation and management of this condition. But first, if you found these videos helpful, don't forget to smash that subscribe button so you have access to more videos like these. So, let's get started. There are two types of heart failure. Heart failure with reduced ejection fraction. This usually results in a very large and floppy heart, which is incapable of performing its function of contracting efficiently. This type of heart failure is usually caused by an infarct, and as a result of this sudden change to the heart structure, remodeling occurs very quickly. The second type of heart failure is known as heart failure with preserved ejection fraction. This is usually caused by hypertension, and the cardiac remodeling here occurs more gradually. There are also classifications based on the New York Heart Association and also the American College of Cardiology, which many will be familiar with. Please see the links in the description box for these. Here are some typical symptoms of heart failure. We could investigate suspected heart failure patients in the following ways. An NT-proBNP blood test. Guidance states that this must be checked in everyone with suspected heart failure, and if positive, to refer for an echo. There are a few things that can cause falsely negative proBNP levels. Some factors can also result in false positive readings. Other bloods outside an NT-proBNP can also be arranged. Other investigations include an ECG, a chest X-ray and spirometry, which may be appropriate depending on your differential diagnosis. NICE guidance really focuses on holistic management in this condition, so we concentrate on what the patient can do, such as stopping smoking. We also look into things such as the mental health, advanced care planning, cardiac rehab, and ensuring that they have their vaccinations. The way we manage these patients will depend on whether they have heart failure with preserved ejection fraction or heart failure with reduced ejection fraction. In heart failure with preserved ejection fraction, the aim here is symptomatic relief, such as the use of low to medium dose diuretics, and also managing any modifiable risk factors, such as hypertension. For heart failure with reduced ejection fraction, we initially commence an ACE inhibitor and a beta blocker. The aim here is to start one drug at a time, and these should be titrated to maximum tolerated doses. So, how do we decide which one to start first? Well, NICE suggests starting an ACE inhibitor first in patients who are clinically fluid overloaded, as beta blockers may initially worsen the symptoms of heart failure. If an ACE inhibitor is not tolerated, such as due to a cough, then an ARB should be used instead. Diuretics may also be used initially for symptom control, such as due to fluid overload. With beta blockers, a start low and go slow strategy should be implemented. The next step, if the patient remains symptomatic, is adding in a mineralocorticoid antagonist. If the patient is still symptomatic, they can be referred for consideration of an SGLT2 inhibitor, such as dapagliflozin and empagliflozin. These medications are both licensed for use in heart failure with or without diabetes. Other medications that secondary care may consider include the following: Outside medication, cardiology may consider implantable defibrillators or cardiac resynchronization therapy. Now, not all drugs that are used in heart failure improve mortality. The only ones that do are the ACE inhibitors and beta blockers when used together. Also, hydralazine and nitrates, also when used together. Lastly, spironolactone. Drugs that may worsen pre-existing heart failure include NSAIDs, beta blockers, calcium channel blockers, thiazolidines such as pioglitazone. Here are some specific referral criteria for heart failure patients. Now, we refer regardless of NT-proBNP if heart failure is due to valvular heart disease. We refer within 6 weeks if NT-proBNP is between 400 and 2000. We refer within 2 weeks if NT-proBNP is more than 2000, as there is a poor prognosis in this group. NICE also say that an NT-proBNP of less than 400 makes heart failure diagnosis less likely, although not impossible. Thanks for watching this video. If you found this helpful and would like to watch more videos like this, please don't forget to like, comment and subscribe, as this will really help my channel to grow.